we will discuss regarding the topic chest pain today. So this is our group member. So this is the case scenario. You observe a medical officer who worked in the emergency room when the paramedic brought in a 50-year-old man who presented with one-day history of severe chest pain. There were a lot of important learning points that you noted during your observation of the MO managing this case. Next. So the first question is list the 5 life-threatening causes for acute chest pain. As we know, acute chest pain can be divided to life-threatening and also non-life-threatening. For the life-threatening, we can divide based on the location of the organ, which is the main organ is heart. It can be acute coronary syndrome or acute pericarditis. For the if the great vessel is affected, it can be aortic dissection. If the lung is suspected, it can be pneumothorax or pulmonary embolism. And other than that, if mediastinum is affected, it can be mediastinitis or esophageal rupture. So next. Uh, so uh, So for each of the listed causes, describe the relevant history and symptom. For the first one, for acute coronary syndrome, based on the location of the pain, it mostly at retrosternal or left chest or epigastric. The character is crushing, tightness and squeezing and also pressuring. Can radiate up to right or left shoulder, arm or jaw. Associated symptom mostly dyspnea, diaphoresis, nausea, and patient can have underlying cardiovascular risk factors such as hypertension, diabetes mellitus, and also dyslipidemia. The next one is acute pericarditis. Mostly the is located at the pain located at the substernal. The character is sharp, constant, or pleuritic. It can radiate to the back, neck, and also shoulder. Mostly the associated symptoms, patient can present with fever, malaise, and myalgia. For the third one, aortic dissection. The location most likely at midline substernal. The character of the pain is tearing, ripping. Mostly radiate to the back, mostly at the intrascapular area. Associated symptom is syncope, pallor, cyanosis, hemiparesis, and high risk in Marfan and also Ehlers-Danlos syndrome. For the fourth one, pneumothorax is normally unilateral pain. It's one side of the chest. The character of the pain sudden, sharp, and also pleuritic pain. Normally radiate to the shoulder or back. Associated symptom is dyspnea and highly causes because of the trauma. And the last one is pulmonary embolism. Location is at substernal. Pain character is pleuritic, which is sudden and intense sharp pain, which is there is no radiation. And then the associated symptoms is hemoptysis, dyspnea, and also have underlying risk factors such as recent surgery, trauma, or recent immobilized. And the third question is the clinical feature for the differential diagnosis. So the first one for SES, patient can appear anxious, distress, and diaphoresis. They can have a stigmata of dyslipidemia such as xanthelasma at the eye and xanthomata at the skin. And from the vital sign, the pulse rate can be irregular or regular. And then for the BP, it can be hypotension or hypertensive. Respiratory rate, it might be increased. And then from the body build, patient mostly high risk. Being obese is high risk for acute coronary syndrome, and patient can have a sign of anemia such as fatigue, pallor, and also palpitation. Patient might present with signs of heart failure also, such as increased JVP, displays impact beats, presence of murmur, and also presence of bypassal crepitation. The next one is acute pericarditis. Normally, patient will appear cyanosis with vital sign low-grade fever because of the inflammation of the pericardium. And so, patient had tachypnea, dyspnea, tachycardia, and also from the auscultation of the heart can hurt pericardial friction rub, which is rasping or creaking sound. Best heard when leaning forward. And the third one is aortic dissection. It's a sudden onset of sharp tearing pain. Patient will appear pallor, cold periphery. Normally from the BP, the systolic BP limb differential is more than 20 millimeter mercury, and also the pulse is deficit. Patient can have a focal neurological deficit such as syncope and altered mental status. And also patient can have signs of aortic regurgitation, diastolic murmur, wide pulse pressure, and also bounding pulse. The fourth one is pneumothorax. Normally it's can occur in thin and tall patient because of the shape of their lung and chest cavity. They're more prone to get pneumothorax. And from the vital sign, it can be tachycardia, tachypnea, and hypotension. There is a presence of signs of respiratory distress, such as use of accessory muscle and also chest retraction. The trachea can be deviated to away from the affected side. In specifically in the tension pneumothorax. From the respiratory examination, it can reduce chest expansion, reduce air entry on the affected side, reduce theta parameters of vocal resonance, and on percussion, it can be hyperresonant. Lastly, for the pulmonary embolism, mostly patient is hemodynamically unstable, which is tachycardic, low oxygen saturation, and also tachypneic. From the respiratory examination, it reduce air entry and reduce chest expansion. And patient can have signs of DVT such as swelling of the leg, cramping pain at the leg, and also redness and warm up at the affected leg. And also from the auscultation can have pleural rub and also can have signs of pleural effusion. Okay. So that's all for so next slide is what are the relevant investigation in acute chest pain and give reason why. So firstly, I would like to do immediate bedside ECG 12 lead to look for any ECG changes which is throughout myocardial STEMI and non-STEMI, and also for if pericarditis, it can be ST elevation also, but in a concave shape. And secondly, I would like to do cardiac biomarker, specifically troponin I and CKMB, throughout for angina or it's a myocardial infarction. If angina, the cardiac biomarker, if unstable angina, the cardiac biomarker will be normal. If MI, it can be elevated. And then the third one is I would like to do food blood count to look for the hemoglobin level for anemic, and also leukocytosis to rule out any infection. And the fourth one is chest X-ray to look for signs of heart failure, such as alveolar edema, curly B line, cardiomegaly, dilated prominent upper lobe vessel, and so presence of pleural effusion. And also, if there is a widened mediastinum suggestive of aortic dissection, and if there is presence of pneumothorax, which is loss of vascular marking, and if present of pericardial infusion, suggestive of pericarditis. The fifth one, I would like to do a random blood sugar to look if patient hypoglycemic because it can precipitate angina, which is can activate the autonomic activation and can cause increased heart rate and increase the heart workload. And the last one, I would like to do renal profile if the patient dehydrated to look for any electrolyte imbalance and acute kidney injury. Next, so The fifth question is discuss the type of cardiac marker in relation to the onset of the chest pain. So basically, we can look for raise on troponin T and I, because when there is a myocardial infarction, it can cause cell death, and there will be release of troponin and high in the cardiac marker. So basically, troponin is the gold standard because it have absolute specificity and high clinical sensitivity for myocardial infarction. It rises within 3 to 4 hours of the onset of MI, and is more likely to be positive 6 hours after the symptom onset. And for the CKMB, it's less specific than troponin because CKMB should rise and fall in the myocardial infarction, but if the value is remain elevated without changes, it most likely due to other cause. So that's all, doctor, for my part.
So any questions for the first part of the presentation?
I think all is clear, Doctor.
Apa dia?
Clear.
All clear?
No.
Okay, we go one by one to the slides. Start from the first slide. Okay, so everybody agrees with the differential the 5 life-threatening cause?
Agree.
Agree, Doctor.
Agree, Doctor.
Agree, doctor.
Okay, so these are the, usually kalau in ED we go for the life-threatening cause, and the commonest life-threatening cause are, so first one should be ACS, acute pericarditis, a bit lower down lah, it's not that common. Pneumothorax, PE, aortic dissection, okay. The other things, kalau the sixth one, maybe you can actually add on esophageal rupture kan. Tapi itu pun is you have to get further history lah, right? Okay, so next. Actually, pneumothorax kalau spontaneous is not life threatening. Acute pericarditis pun is not that life threatening actually, unless they develop apa.
Pericardial effusion.
Pericardial effusion.
Pericardial effusion itself also is not a life-threatening condition. What is the life-threatening condition?
Cardiac tamponade.
Yes, okay. Cardiac tamponade lah. Alright, but cardiac tamponade is not a diagnosis kan. Cardiac tamponade is usually secondary to what? Alright. Okay. I think this one should be straightforward, tak ada apa sangat. Okay, next. Oh, sekejap macam PE ni kan, the associated symptoms just now. Do you know of any criteria or what history that actually you want to ask to say that this patient has a high probability to get PE or DVT? Dia lebih kurang sama lah. Classification.
Wells criteria.
Do you know what is Wells criteria?
I know, but I don't remember the.
Anyone else? Anybody else yang ingat?
So basically the component, it has about any history of any clinical symptoms of the DVT, and tachycardia, any previous DVT or pulmonary embolism, hemoptysis, any done surgery or immunization in the previous 4 weeks, and ada lagi banyak, Doktor.
Okay, so you kata recent surgery tu how recent?
In the previous 4 weeks.
Okay, so what kind of surgery? Kalau buat IND kira macam mana? Is it
Major.
one of the risk factor?
No, it's major surgery.
Dia major surgery
Macam
kalau macam you buat TKR ke kan, ataupun you buat some intra-abdominal surgery, all this major surgery lah. Kalau yang minor surgery, IND je ke tu tak ada lah kan, so it's not a risk. Alright. Okay, so actually you all pernah dengar tak MD calculator? Dia ni macam apps lah.
Pernah.
Okay, so benda-benda ni sebanyak je. Sekarang kita kat ED we usually use sort of scoring criteria to actually risk stratify patients. Okay, we use that a lot, right? So for PE or DVT we use Wells criteria. Okay, so we have to score them. Are there the low risk, moderate risk, or the high risk? Because the investigation will differ lah according to the risk criteria. Okay. So next page. Okay, question 3 je. Question 3. Okay, alright. Okay. Nak tanya lah, acute pericarditis ada cyanosis Kenapa
If cardiac tamponade.
Okay, why do you have cyanosis? What's the macam mana boleh dapat cyanosis?
Reduce oxygenated blood.
Okay, alright. So dia ada ni kan deoxyhemoglobin something kan, punya level tu. So patient will appear blue kan. Okay, so for in cardiac tamponade, so apa akan jadi? Kenapa ataupun acute pericarditis lah kan, sebab you punya disorder acute pericarditis, clinical feature cyanosis. So how does that relate? So you prepare presentation ni, you daripada mana dapat ni reference ni clinical features?
Dari buku. Tapi not stated why. Just mention the sinus.
So kenapa dia sinus kan? Acute pericarditis usually tak affect lung kan?
Yeah. Pericardic, if pericardic.
Pericardial effusion pun patient selalunya dia tak sinus pun. But cyanosis is very specific sebab dia deoxygenated blood kan. And usually kenapa dia sinus sebab macam ada right to life shunt kan, macam you punya your congenital heart disease, right? Okay, or there's a problem with the lung lah, meaning there's a poor oxygenation, so dia boleh dapat cyanosis lah. So we don't really associate cyanosis with acute pericarditis lah. Even cardiac tamponade pun actually dia tak sinus, tapi sebab dia nampak sebab dia hypotensive kan. So patient will look pale. It doesn't look sinus, dia nampak pale. Okay, sebab BP low, hypotensive. So I don't think cyanosis is the correct clinical feature lah for acute pericarditis. The commonest apa for acute pericarditis clinical feature? Besides chest pain lah.
Pericardial friction rub.
Tu pun yelah, not all can actually detect that, right? Okay, lagi.
Hypotension.
Yelah, tu kalau dia dapat tamponade. Tapi kalau just a small pericardic effusion, just a simple pericarditis, bolehlah boleh dapat myocarditis lah. Kalau kan myocarditis bolehlah dapat low BP sikit. So usually dia macam palpitation lah kan, palpitation and also some low grade fever, and they will have some bit of SOB, tachypnea lah just now. Okay. 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 So you mentioned in pneumothorax, this patient will have tachycardia, tachypnea, and hypotension. Do all pneumothorax will develop these three things?
Not
So what type of pneumothorax you akan dapat?
tension.
Okay, so you cannot generalize. It's very specific. Pneumothorax tu dia ada simple pneumothorax, so simple. So sama ada is spontaneous, primary, secondary, or or primary or secondary. Lepas tu there's the life-threatening condition is the tension pneumothorax. Okay, so sepatutnya hypotension tu masuk under tension pneumothorax tu lah. Okay. So why does tension pneumothorax cause hypotension? Anyone know?
Sebab dia deviate the mediastinum, so reduce in for blood to pump to all parts of the body.
Okay, itu CP lah. Tapi apa sebabnya sebenarnya?
Because
Kenapa dia boleh shift the mediastinum? Kenapa?
increase in the pressure increase the pressure in the hemithorax.
Okay, so it's actually the intrathoracic pressure to increase kan? Sebab dia punya pleura tu dah penuh dengan angin. So dia increase pressure in the intrathoracic cavity. Betul tak? Dia bukan dalam kan? It's actually at the intrapleural space. So apa akan berlaku kalau increase pressure in the intrathoracic cavity?
Then the mediastinal shift.
So what dia hypotension sebab cardiac output low kan? So macam mana cardiac output tu boleh low?
Because decrease blood return to the right atrium.
So dia apa kita panggil tu? Preload kan?
Preload.
So reduce venous return kan? Reduce preload, right? So heart from the IVC tu atau SVC tak boleh masuk. Blood tu tak boleh masuk kat right atrium. So kita panggil reduce preload, reduce afterload. So reduce preload, reduce venous return. Sorry. Okay. So when you have reduced preload, so your cardiac output low lah. Betul tak? Ingat tak formula cardiac output apa? Belajar kan? Tak apa, nanti boleh baca balik. Okay, alright. So I think you have to know why this clinical features is associated with the underlying cause lah. Why the hypotension develop kan? Why dapat cyanosis in certain condition kan? So I think you have to know basic things tu kena tahu lah. Okay. Alright. So for PE, sebenarnya PE tak semuanya hemodynamically unstable. Ada yang stable. So actually PE tu dia ada banyak kategori lah. Dia ada stable, actually dia ada massive, submassive. Lepas tu stable. So tapi tu macam advance sikit lah. Tapi the moral of the story is actually PE tak semestinya unstable lah. It can be stable PE, right? Anything else you want to ask regarding this third question? Tak ada. Okay, we go to the next question, nombor 4. Okay, so macam soalan nombor 1, the first investigation ECG 12 lead ECG kan. Dia tak adalah cakap nak rule out STEMI atau non-STEMI saja. So I think when you want to answer, you should say that you want to look for ischemic changes lah, or STT changes, right? Okay, because besides STEMI, you want to look for other things as well, right? Macam pericarditis, right? Okay, so then I think that's how you want to reason why you do ECG lah. What is the appearance of pericardial effusion in X-ray? Ini nombor 4 tu. Because you don't actually see pericardial effusion in X-ray kan. You nampak heart border je kan. Do you know of any like classical punya criteria untuk describe possibility there's pericardial effusion?
It's actually we can see a globular enlargement of the cardiac showing a water bottle configuration.
Yes, water bottle ke ada kata boot shape kan. So that is actually what you see in the X-ray. You tak nampak effusion. Effusion you kena buat echo. Baru you nampak effusion. Okay. So it's actually the terminology tu. Okay, alright. So question 5. Yang ni quite straightforward lah. You ambil daripada ni kan, Malaysia Guideline kan, CPG. Okay, so I think you have to know what are the types of cardiac biomarkers lah. Right. Okay. And the first detection tu bila. So kenapa kena tahu? Why do you think that we have to know the time semua ni? It's important to know kan? Kenapa?
More sensitive to detect.
Okay, lagi? Ada apa-apa lagi sebab lain tak? Kalau kita tengok patient kan, lepas tu kita dapat result. So macam mana kita nak kaitkan result tu dengan patient? Berdasarkan the detection rate, the detection hours tu. Faham tak soalan?
For intervention later, maybe decide for PCI or thrombolytic therapy.
Okay, alright. Okay, first, kalau you ada STEMI, kan, ST elevation, or sekarang you orang panggil apa? ST elevation ACS kan? STE ACS something, right? Is actually you tak tengok pun troponin tu, lantak dia lah kan. Tapi kita tengok hours onset tu kan. Onset of chest pain tu bila. ECG dah ada changes. But criteria kan, you tahu ada 3 criteria, right? You have to fulfill 2 out of 3 kan. Diagnosis of STEMI. Tu kena baca CPG lah. Right?
Rise of fall.
Fall tu sebab usually kenapa drop eye ni kalau you hantar kat lab 1 jam pun siap. Takkan nak tunggu 1 jam baru nak decide kan. Because time is muscle, right? The longer you wait, the more damage tissue is there. So selalunya untuk MI ni kita tak guna pun drop eye tu. Kita guna clinical and also your ECG, right? But then your cardiac biomarkers ni penting in your other spectrums of ACS lah, macam you punya non-STEMI kan, your unstable angina or stable angina. Okay, the basis of why we want to know the time of first detection ni sebab kita tak tahu sama ada perlu repeat atau tidak lah. Kena buat serial ke tak, kan? Kita tak tahu patient tu chest pain tu pukul berapa. Kalau dia datang within 2 hours of presentation, so we know that your troponin will not raise. Kan, you will be normal. So mungkin kena repeat balik lah nak tengok sama ada the troponin tu akan naik atau tak. repeat another 3 hours ke apa. So that's why we have to know lah, kan. And the other thing, kita nak tahu duration of detection tu. Right? So we know trop T or trop I, dia akan persist about 2 weeks. So it can still be elevated, but we can do another trop I to see if the repeated trop I tu akan lagi tinggi ke apa lah, untuk menentukan sama ada another attack or not. Right? So that's why you have to know. Okay? Okay, faham. Myoglobulin selalunya tak ada lah untuk hospital. Mungkin certain tempat je macam IJN mungkin ada lah. But most of the hospital tak ada myoglobin. Even kat KKM pun sometimes tak ada troponin atau CKMB tu. Dia cuma ada the CK, LDH dengan apa lagi satu? ALT kot. It's actually the cardiac enzyme yang less sensitive or less specific, right? Tak semua hospital ada troponin or CKMB. So that's the challenge lah. Okay, any other things that you want to ask? The first part of the presentation before we move on? Okay tak?
Okay, doktor.
Okay, doktor.
Okay, so we go to the next part.
Okay, Assalamualaikum Dr. Assalamualaikum and good morning Dr. and friends. So I'll continue with how to perform the left-sided 12-lead ECG. Okay, first, as always, introduce ourselves and obtain consent, get a chaperone and ensure privacy. Make sure our hands are clean, and then make sure patient lying flat or a semi-recumbent position of approximately 45 degrees to the horizontal. And then we expose the chest, do skin preparation such as removal of hair or skin cleansing. And then we proceed to the precordial electrode placement. Okay, first we start with the electrode V1. We put at the fourth intercostal space to the right of the sternum, and then take electrode V2 at the fourth intercostal space to the left of the sternum. And then we take electrode V4. V4 we put at the fifth intercostal space at the mid clavicular line. And then V3 is midway between the V2 and V4. Then take electrode V5 at the same level with V4 at the left anterior axillary line. And lastly, the electrode V6 level along with the level of V5 at the left mid axillary line. And then we proceed with the limb electrode. Okay, for limb electrode, we can use the color to guide us. Okay, so the white one we can put the right arm, left the black one at the left arm, right one at the left leg, and the green one at the right leg. Next. Okay, then we switch on the ECG machine, and with the standard ECG recording paper speed of 25 millimeter per second with a voltage of 10 millimeter per millivolt. We put in the patient's details and confirm details with the patient, ask the patient to relax and be comfortable, because somatic muscle potentials can affect the quality of ECG. Then we initiate recording with the start or auto button, and we print. Okay, then we remove electrodes from patient and dispose, switch off the ECG machine, and then the ECG should be correctly labeled with the patient's identification, and we put any relevant clinical details and also if any adjustments have been made. Next. Okay, this is the left-sided 12-lead ECG of the patient. So we need to interpret and give the diagnosis. So we start off with this ECG belongs to Mr. X, 50 years old man, taken on which time. And then the rhythm is sinus and regular with heart rate of 60 beats per minute. And there's presence of left axis deviation, and which might be because of the left ventricular hypertrophy. And there's also a presence of P wave, normal PR interval, and QRS complex. So for the abnormal changes, there is XT segment elevation at the lead 2, 3 AVF. I've put the red circle there. And there's also pathological Q waves at lead 2, 3 AVF. And the green one, we can see reciprocal changes, ST depression at the lead AVL. So a diagnosis is acute inferior ST elevation myocardial infarction. Next. Okay, how can we relate the ECG changes with the coronary artery? So for the V1 lead V1 to V4, it is it shows the left anterior descending artery supplies punya problem. And then at the high lateral lead is lead 1 in AVL, which might be because of the occlusion of left circumflex artery or diagonal branch of left anterior descending artery. And the low lateral leads also V5 and V6 can be due to occlusion of left circumflex artery or diagonal branch of left anterior descending artery. And inferior leads, which are lead 2, lead 3, and lead AVF, can be due to occlusion of right coronary artery or the left circumflex artery. Next. Okay, so based on the ECG changes, which coronary artery is involved? So the ECG changes is at the lead 2, 3, and AVF. So the most likely causes occlusion is at the right coronary artery, because this is 80% of inferior stemmi is due to the right coronary artery occlusion, but there's also can be 20% chance of left circumflex artery occlusion. But we can see there is ST elevation in lead 3, which is more prominent than lead 2, and there is presence of reciprocal changes in the lead AVL. But in left circumflex artery occlusion, the ST elevation in lead 3 is equal to lead 2, and there is absence of reciprocal changes. That's all for my part. Any question?
Semua setuju. Okay, kita tengok gambar sekejap. Okay, alright. So, usually kalau ECG leads tu dia ada label kan. So, just follow the label lah, right? So, sometimes your RA dengan LA tu tak semestinya colour putih atau hitam lah. Tengok dia punya lead tu. Okay, so this colour is just the reference, tapi tak semestinya when you see the ECG machine, it follow the colours, right? So, it's best is actually you see the labeling, right? Tapi yang selalu label tu actually the limb leads lah. Yang pericardial leads ni, yang V1 sampai V6 tu is what you call that, tak kisahlah. Boleh, you just letak mana-mana dia sama je. But you have to know the position. Do we usually do V4R ni? Ini untuk apa sebenarnya V4R tu?
V4R is to confirm right ventricular MI.
Okay, so kita tengok RV infarct. Okay. Tapi sometimes kita tak guna V4R, kita sambung je. So kita ambil 4, 5, 6 tu kita letak. So kita tengok, nanti kita tengok lead 4, 5, 6 nanti. Right. Okay, next slide. Next slide. Next slide. Okay, so semua setuju with the ECG diagnosis? And the ECG interpretation?
Setuju, doktor.
Setuju. Okay, kenapa you kata left axis deviation
Because the lead 1 is more positive and the lead 3 is negative.
Tapi tu sebab dia ada pathological Q wave kan. And tadi you mention patient ni ada LVH. Most likely LAD secondary to LVH. So kenapa you kata LVH What are the criteria LVH that you see in this ECG?
It can be LVH because of the left axis deviation, but as doctor said, the left axis deviation might be because of the pathological Q wave.
So tak jadi dah left axis deviation tu. Sebab sometimes you tengok, yang biasa tengok lead 1 dengan lead 3 kan, kadang, tapi another way is actually you tengok lead 2 and lead ABF as well. Lead 1 ABF. So macam dia macam more positif kan, macam normal axis. Okay. Tapi tadi macam you kata LVH tu, do you know of any ECG criteria that actually give a clue that this is LVH?
Yes, doctor. Where they got circular line criteria and it must fulfill the voltage and non-voltage. That one I will explain during my part.
Oh, okay. You can explain. Alright. Okay. So then okay. So next. So tapi yang penting, if you want to say MI, dia kena ada reciprocal changes. Alright. So like this ECG kan. It's because dia macam ECG macam vector kan. Right. So kalau dah ada part tu positif, dah ada part yang macam reciprocal changes. Ni macam tak. Ni your lateral leads kan, AVL tu kan ada reciprocal changes Right. Sebab dia akan reflect. Okay. Positif negatif. Kalau semua macam sama je kan, tak ada reciprocal, so it's very unlikely is MI. And also you have to selalunya kita tahu most likely MI is actually the changes of ST elevation tu is according to the coronary blood distribution. Kalau dia macam haphazard kan, rata-rata tempat, so macam is very unlikely to be MI lah. Okay. So next. Tengok nombor 8 tadi. So sebab tu you kena tahu ni the location of infarct will actually you akan nampak dekat lead mana. Okay, because usually kalau MI dia akan reflect the circulation, the coronary circulation. Okay, ni pun soalan favourite ni kalau untuk long case. Next. ACS kena tahu in out memang akan keluar lah ni. Kalau siapa yang dapat medical case tu, most likely memang case ACS lah keluar. So, okay. So, RCA. Alright. Yelah, sebab selalunya memang 80% is RCA dominant kan. Okay, next. Okay lah. So, the third part boleh present.
Okay, good morning everyone. Dr. Dazlin and my colleague. So I will continue with question number 10, other bedside investigation that I would like to do and the value for each investigation. So this is the list for the bedside investigation. As we know, bedside investigation meaning the point of care testing. So as Asmira has already mentioned about the dystrophic, cardiac biomarker, portable accessories, so I like to add as this patient already diagnosed with inferior MI, so we have to do the right-sided ECG to rule out any right ventricular MI or posterior MI because they are sharing the same vascular supply, which is right coronary artery. And we also should do bedside echocardiogram to assess for any myocardial damage. So to check for LV and RV abnormality, any wall motion abnormalities, and post-infarct mechanical complication. And as doctor said, one of the differential also should be esophageal rupture. Then we also can do the ultrasound of the abdomen. Okay, next slide. So question number 11, other conditions that may present with ST elevation and how to differentiate with acute MI. So these are some lists that the condition that may present with ST elevation. One of it is acute pericarditis, Prince metal angina, left bundle branch block, left ventricular hypertrophy, hyperkalemia, and Brugada syndrome. So in the next slide, I will explain brief about what the ECG diagnostic criteria for each diagnosis. So for the acute pericarditis, it is an inflammation of the pericardium, the thin side that cover the heart. So the ECG diagnostic criteria, it must have the widespread concave, or we known as saddle-shaped ST elevation and PR depression throughout most of the limb leads 1 to 3 AVL and AVF, and the precordial leads V2 to V6. And next is also got reciprocal ST depression and PR elevation in mixed AVR plus minus B1. And we commonly found sinus tachycardia in the ECG because of the pain and or pericardial effusion. And the acute pericarditis in the ECG will rather static and change slowly over several days to weeks. Okay, as you can see in the table below, I put there is a 4 stages. So for the stage 1 is usually occurs in the first 2 weeks where there will be diffuse ST segment elevation and reciprocal PR segment elevation. And for the stage 2 occurs in 1 to 3 weeks where the ST segments will be normalized as well as the PR. And for the stage 3 occurs in 3 to several weeks where there will be widespread T wave inversion, and several weeks onward the T wave will be normalized. So next slide. Then left ventricular hypertrophy. So as Dr. Azlin asked this now, so the ECG diagnostic criteria is circular line criteria. Okay, you can see in the table ECG on your left side. So that one is a circular line criteria where the S wave depth in V1 or V2 and plus the tallest R wave in the V5 or V6 must be more than 35 millimeter, and it must be accompanied by the voltage criteria and non-voltage criteria. So to be considered diagnostic of the LVH. So any one of the criteria, if it's present, then is enough to diagnose as LVH. Next slide. Okay, this is the example. As you can see, A to E is the voltage criteria, while F is non-voltage criteria. So you can see in the slide, S wave in V1 is 70 millimeter, plus R wave in the V5 is 24 millimeter, equivalent to 41 mm. Where just now I said it should be more than 35 to diagnose. And then number 2, picture number B, the deepest S is 28 millimeter at the V2, and the tallest R is 24 millimeter, which is 52 millimeter, more than 45 millimeter. And then picture number 3 is S wave in the V3 is 23 millimeter plus R in the AVL is 40 millimeter, equivalent to 37, where it is higher than 28 millimeter for men and 20 millimeter for women. Picture number D and E is R wave in the AVL is more than 11 millimeter because is 20 millimeter, which is more than 11 millimeter. R wave in the left one is 21 millimeter, which is more than 12 millimeter. And for the diagnostic criteria, we can see there is a string pattern at the with T wave inversion in V5, V6 plus one let's lead one and AVL. Okay, next slide. Okay, however, when the ECG has fulfilled both voltage and non-voltage criteria, then the diagnosis will be LVH. However, before diagnose LVH, we have to ensure that this is not the LBBB, because LBBB and LVH it share the same ECG feature except for the broad singular R wave, which is usually broad monophasic in the lateral leads 1 AVL and V5 to V6. Okay, so it is associated features with appropriate discordant. ST segment and T wave go in the opposite direction to the main vector of QRS complex, and they got poor R wave progression and left axis deviation. So you can see in the ECG QRS morphology in the lateral leads, the singular R wave may either be notch, notch in the ECG at your right side, notch, M shape, RS complex, and monophasic. Okay, next slide. And QRS morphology in the V1, they can be either RS complex where the wave is small and the S wave is deep. Okay. Or can be QS complex where deep Q or S wave with no preceding R wave. So below is the modified Scarbosa criteria. This one is actually can be used in both LBBB and the pace ventricular rhythm with LBB morphology to assess the presence of the concurrent STEMI. So before we diagnose LBBB, we have to ensure that this is not an LBBB mimics. We have to look at the presence of any spike at the beginning of the broad QRS complex with LBB features, because if there is presence of spike, then the diagnosis will be pace ventricular rhythm. As you can see in the diagram on your left side. Okay, ECG. So the criteria of the modified Scarbosa criteria it consists of concordant ST elevation equal or more than 1 millimeter in at least 1 lead, concordant ST depression equal or more 1 millimeter in at least 1 lead of V1 to V3, proportionally excessive discordant ST elevation in equal or more than 1 lead anywhere with equal to 1 millimeter S elevation as defined by more than 25% of the depth of the preceding S wave. So you can see on your the diagram below, I already put A, B, C. So that one is actually the example of the concordant ST elevation, concordant ST depression, and the proportionally excessive discordant ST elevation. And number D, abnormal repolarization should be followed by abnormal repolarization manifesting as ST segment and T wave deviation that do not necessarily indicate acute ischemia. Okay, next slide. So this is a summary of the condition that may present with ST elevation and the ECG changes. So this source I get from the Stanford .edu. You can refer to the table later. Next slide. So last question is the management of the patient. So the management in terms of the monitoring, definitive, supportive, and the disposition of the patient. So for the early management of STEMI, we actually directed at the pain relief to establish the early reperfusion and the treatment of the complication. So we have to monitor the vital sign to assess for assessment and stabilization of hemodynamic, such as pulse rate, respiratory rate, SpO2, and blood pressure. So pulse rate, tachycardia, respiratory rate is respiratory depression, SpO2 because we have to give oxygen via nasopron at 2 to 4 liter per minute to keep the SpO2 over 95%. And BP, blood pressure to check for hypertension, which might indicate there is a cardiogenic shock or rupture, and hypertension can be due to the pain. And continuous ECG monitoring should be commenced as soon as the diagnosis of the STEMI is made. And for the initial treatment, we have to give patient analgesic with titrated IV morphine at 2 to 5 mg slow bolus injection 5 to 50 minutes as necessary. And we should watch out for hypertension and respiratory depression. Together with the anti-emetic IV metoclopramide 10 mg 8 hourly. And we can give 1 dose of sublingual GTN if the chest pain persists and if there is no contraindication. 300 mg soluble aspirin and 300 mg clopidogrel. Okay, so next is the definitive treatment. So this is, I know everyone will be familiar with this diagram because this I took from the CPG. So this is the flow chart for chest pain management, for MI STEMI management. So we can see for early, the assessment of the reperfusion depends on the onset of the symptoms. So for early presentation, which less than 3 hours, usually we will choose a primary PCI or fibrinolytic therapy that is shown to be equally effective. However, for late presentation, 3 to 12 hours, we will prefer primary PCI. And for very late presentation, which is more than 12 hours, we will, if patient is asymptomatic and hemodynamically stable, then we will go for medical therapy plus minus antithrombotic. However, if patient has persistent ischemic symptoms, then primary PCI is preferred. So since this patient present late to us, which is more than 12 hours, and if he still has persistent symptoms, then the primary PCI is the preferred deperfusion therapy for his STEMI. Okay, next slide. So primary percutaneous coronary intervention. So primary PCI is superior to the fibrinolysis when it is done in a timely manner. Um, so it is a non-surgical procedure, but invasive, with a goal to relieve the narrowing or occlusion of the coronary artery and improve the blood supply to the ischemic tissue. So at the PCI facility, the ideal door to balloon time should be equal or less than 90 minutes. The definition of the door to the balloon time is the time taken between the patient arrival to the balloon inflation during the angiogram. While we expect the duration will be less or equal to 120 if the center did not have primary PCI, and we expected some delay because of the transfer. However, if the time is more than 120 minutes, then the best option is we give the fibrinolytic therapy and make arrangement to transfer the patient to PCI capable center for a pharmacoinvasive strategy. So in the flowchart below is the procedure for the primary PCI. So pre-procedure, we should give patient dual antiplatelet therapy, which consists of aspirin 300 mg plus clopidogrel 300 to 600 mg loading asap, and give patient with anticoagulant with unfractionated heparin. And during the procedure, the access to the bloodstream is usually achieved through either the femoral or radial artery. But in general, radial artery is preferred because it reduces the risk of excess side bleeding, as the radial artery can be easily compressed against the radial bone compared to the femoral artery. However, it requires for the radial artery, it requires expertise, experience because of its small size. And we also do stenting during the PCI. For the post procedure, we should give patient, we should stop anticoagulant and continue the dual antiplatelet for 12 months. Next slide. Okay, this is like briefly about fibrinolytic therapy. So the golden hour to administer is within 2 hours of the symptom onset, where it is the most beneficial and has been shown to avoid the infarction and reduce the mortality by up to 50%. In the golden hour, when the symptom duration is within 1 to 2 hours, then the prompt fibrinolytic therapy may provide clinical benefits compared with primary PCI. So for fibrinolytic therapy, the ideal door to needle time should be within 30 minutes, and this is the choice of the fibrinolytic agent, streptokinase and the teneteplas. So for the streptokinase, the regime is 1.5 mega units in 100 cc normal saline. That's 5% over 1 hour. For the teneteplas, it is a regime. It is a weight-based regime. So there is a risk of bleeding if the weight has overestimate. As you can see, and at the table below, it depends on the weight of the patient. So if patient is less than 60 kg, then we will give 30 milligram. Of the teneteplas, and 60 to less than 70, 35, 70 to less than 80 kg, 40 mg, 80 to less than 90 kg is 45 mg, and more than 90 kilogram is 50 milligram. And after we done with the administration, we should reassess back the patient, because patient can get bleeding and as well can get the reperfusion arrhythmia, which can lead to a ventricular tachycardia or ventricular fibrillation. That's why during the procedure, we should put patient on cardiac monitoring as patient can go to the ventricular tachycardia and ventricular fibrillation. And following the administration, we should give patient anticoagulant for at least 48 hours. Next slide. Next slide is the contraindication to the FT. Okay, where it will divide it into the risk of the intracranial hemorrhage and risk of the bleeding. For the risk of the intracranial hemorrhage, there is a history of intracranial bleeding, history of the ischemic stroke within 3 months. Patient is a known structural cerebral vascular lesion and intracranial neoplasm. For the risk of bleeding, he got either patient got active bleeding or bleeding diathesis, but we must exclude the menses, any significant head trauma within the 3 months, and if we suspected this is a aortic dissection, then we cannot do the fibrinolytic therapy. Next. Next is supportive treatment. So in terms of supportive treatment, it can be divided into pharmacological and non-pharmacological. For the pharmacological, we have dual antiplatelet therapy where aspirin 75 till 100 mg daily, plus usually we will pick clopidogrel plus clopidogrel 75 mg daily for at least 12 months to reduce the vascular event. And number 2, anticoagulant. For patients that receive the fibrinolytic therapy, then we can give unfractionated heparin or low molecular weight heparin, which is a taxane, and factor 10 inhibitor fondaparinux. And then number 3 is beta blocker. When if patient is not contraindicated, then we can give beta blocker. This is the medication that is available, such as metoprolol, carvedilol, and bisoprolol. Okay, next. Then number 4 is ACE inhibitor or ARB. So this is indicated to start in all STEMI patient within the first 24 hours. But in patient with ACE inhibitor intolerant, we can give ARB instead. So when giving the ACE inhibitor, we should monitor the renal profile as patient can get increased AKI, within 2 weeks of initiation. That's why we have to reduce or stop if there is an increase in serum creatinine of more than 30% from the baseline within 2 weeks of initiation, and there is a persistent hyperkalemia, more than 5.6 millimole per liter. And then number 5 is statin. We can start patient on high intensity statin therapy such as atorvastatin or rosuvastatin. And our target LDL should be less than 1.5 millimole per liter or reduction or at least 50% from the baseline. The lower the better. Next. Okay, next is number 6, MRA, mineralocorticoid receptor antagonist, spironolactone. So this one we give for patient that have left ventricular ejection fraction less than 40% or with heart failure. And as I mentioned, for the it also got non-pharmacological management. So for the non-pharmacological management, we got cessation of the smoking, where we have the quit smoking services, dietary modification and weight control, such as reduce the salt intake and limit the alcohol intake. And next is physical activity, where we got cardiac rehabilitation program. So under rehab program, cardiac rehab, we have exercise training program where it consists of the warm-up, main exercise, and the cool-down. And the sexual activity also have to resume 1 week after uncomplicated STEMI in the absence of the cardiac symptoms after mild to moderate physical activity. Yes, that's all from me. Abida. Disposition. Okay, disposition of this patient. So all STEMI patients should be admitted to the CCU or equivalent unit that have the monitoring facility. And if the patient did not have any complicated case or complaint, then we can keep the patient in the CCU for a minimum of 24 hours before we transfer them to a step down unit. But patient that have a complicated STEMI, we have to keep them longer in the CCU unit. And then the general condition of the patient should be continuously monitored following the STEMI, such as vital sign, pulse oximetry, and the cardiac rhythm. And the blood pressure prior to start ACE inhibitor or beta blockers. Early referral for the cardiac rehabilitation is advisable. That's all. Thank you. Any question? That's right, Tama. Okay.
Okay, so thank you for a quite detailed and lengthy punya plan of management, all that. So, any question for the presenter? Okay, do you know how to do a posterior lead ECG?
We put V7 to V posterior ECG is V7 to V9.
So V7 V9 tu letak mana? What is the landmark? Kita boleh tunjuk gambar yang nombor berapa tadi? Okay. Nombor 6 tu tapi ni tak nampak pula kan. So kat mana nak buat? Where do you put the 7, 8, 9?
Dekat right side.
Right side. Right side tu dah
Right.
RV kan? Right ventricle.
Oh sorry, at the back.
At the back tu.
At the back maksudnya kat mana?
Dekat left.
Bawah scapula.
Bawah scapula.
Bawah scapula 1. Bawah scapula kat mana? Dekat tepi, dekat tip. Tak ada gambar bahagian belakang kan. So basically guys, 7, 8, 9. So 8 is actually at the inferior tip of the scapula kan. Okay, 9 is usually dekat
paraspinal.
Yes, okay. So 7 is in between 6 dengan 8 lah. So selalunya patient kita akan mengiringkan patient untuk buat benda tu. Right. Okay, so lepas tu I think right. Soalan nombor 11 tu I think you've explained quite detailed. So well, it's good to know the criteria, all that, but I think for your level is macam LVH kena tahulah kan, at least it doesn't need to fulfill all the criteria, but at least you know the common ones lah, macam yang it has to be more than 35 mm kan, yung the RNS tu semua. Okay, and also the LV strain pattern. Okay, you have to know about pericarditis, ECG changes pun kena tahu. LBBB, okay, so if you know about the Scarbosa criteria, then it's good lah. Alright, but at least you know that the appearance of LBBB tu macam mana lah. Okay? So LBBB usually dia ada widened QRS complex lah. That's why dia ada block kan. So dia akan menyebabkan widened QRS complex compared to your LBH, dia punya QRS complex dia narrow kan. Alright. Can you go back to the management of MI? Soalan nombor 12. Okay, so tengok yang flow chart tadi. Algorithm. Okay, so ni semua okay? Semua okay? Tak ada masalah?
Okay, doktor.
Just nak tanya yang preferred option in high risk patient. So apa maksudnya is actually PCI kan, 3 to 12 hours primary PCI is actually preferred option kan. So tapi kalau tak ada facility, then you have to give lytic therapy lah. But then what do you mean by high risk patient?
High risk patient, contohnya patient that have large infarct, anterior infarct, hypotension, patient got cardiogenic shock, got significant arrhythmia, elderly, post CABG or post PCI and post infarct angina.
Yeah, so itu kena tahulah okay. Alright, sometimes they will ask actually. So next slide. Ya, ada yang sebelum ni. Ada yang cakap pasal Mona therapy tu mana? Ni, okay.
Actually doktor, soalan dia pasal monitoring je. Tapi sebabkan saya masukkan yang Mona, morfin itu semua, saya ada tambah and initial treatment.
Okay. Alright, tak apa. Sebenarnya kan tak semua patient kita bagi oksigen Kita hanya bagi oksigen kalau SpO2 tu less than 92% je. So kalau 93% pun kita accept, tak payah bagi oksigen. Do you know why?
92% baru bagi oksigen doktor?
Less than 92.
Less than 92.
That's the new guideline. Tapi CPG Malaysia ni tak tahu dia dah update ke belum. Saya dah update dah. So do you know why? Kenapa tak nak bagi oksigen banyak-banyak?
Tak sure.
So oksigen ni macam is actually macam you punya medication lah kan. It's actually your drug therapy lah. Cuma dia bentuk gas je. Right. So we don't want oxygen radicals lah basically. Too much oxygen will be harmful for the muscle kan. Oxygen radicals will actually damage the muscle more. Right. So we just give enough. So 92% tu kira okay lah. Tak payahlah nak bagi extra. Sebab your muscles dah damage We don't want to put further insult to the muscle. Okay. So for analgesia, yes, we will give morphine, but we don't usually give it as a first line. Kita bagi nitrates dulu. Okay. Kita bagi GTN sublingual dulu. Kalau do you know berapa banyak maximum dose GTN kita nak bagi? Bagi satu je ke atau kita boleh bagi multiple times?
Up to 3 times, doctor.
So how do you give to up to 3 times to interval dia?
5-minute interval.
Yes, okay. So GTN ni selalu dia fast acting So dia masuk sublingual, jangan suruh patient tu crush pula kan. Sublingual, then I think about 1 to 2 minutes. Kalau chest pain tu still not resolved, then buang and letak lagi satu yang baru. Okay, right. So if still the chest pain persists, then you should consider morphine as well as intravenous infusion of GTN. Okay. So Maxolon or metoclopramide pun is not the usual medication. It's not macam bagi morphine ke apa wajib bagi. Tak, if patient is PRN basis lah, kalau patient vomiting apa baru bagi, right? Okay. Right, so next page. Okay, so ini okay. Next. Ini ke belakang ke depan ni? Okay, so there are few terminology you have to know lah. Okay, macam door to balloon, okay, inter-facility transfer, and also door to needle time. Tu semua kena tahu lah. Alright. Tadi you cakap ASAP tu apa? What do you mean by ASAP? Ada pre-procedure preparation, dia cakap apa? loading asap
Ah,
It's ASAP ASAP or
ASAP.
ASAP. So apa benda
Okay.
tu? What's that? What does that mean?
Uh,
As soon as possible.
Yeah, as soon as possible, right? Bukan asap lah, bukan smoke macam smoke.
ya betul.
Okay, so next slide. Okay, alright. Ini ni. Okay, golden hour. So most of the centers still use streptokinase. Tapi kat HUCAM we use either tenecteplase ataupun nama glamour dia metalase ataupun altiplase lah. This both is RTPA. Okay, streptokinase we reserve to macam patient yang macam tak boleh bayar lah, macam foreigners, okay, or the high risk group semua tu. Okay, so yes, RTPA usually is weight dependent, but the risk of hemorrhage is actually less. Dia macam is a very small risk lah, less than 5% risk of bleeding. Okay, compared to streptokinase. Okay, so okay, next page. Okay, so before giving any lipid therapy, you have to know the absolute contraindication. Ni semua ni is actually absolute contraindication. Dia ada relative contraindication, right? But at least you know absolute contraindication is good enough. Next slide.
Betul, kalau if patient got relative contraindication, can we still consider can give FT?
Lah kita kena risk the benefit. Is the benefit outweigh the risk? Dan kita bagilah, especially time sekarang kan. Kalau nak pergi PCI kena buat RTK antigen dulu. So semua patient lytic therapy dan kena buat rescue PCI later. So you tengoklah the risk kena weigh the pro and cons. Okay lah, ni tak ada apa sangat lah. Alright, okay. The other thing is that you should know how do you know that the lytic therapy is successful. Kan you dah bagi kan? Sebab sekarang ni posting ED bukan posting medical. So you bagi lytic therapy. Okay, so how do you know that your lytic therapy is successful? You tak present kan tadi?
Sebenarnya doktor, apa is successful?
Katakan you bagi tenecteplase kat patient kan? So, macam mana you nak tahu tenecteplase tu berjaya atau tak? Itu penting tu, kat ED setting penting.
Resolve of the chest pain, doktor.
Okay,
Dengan
lagi?
yang ECG dia ST2 back to isoelectric line.
Only back to isoelectric line. Kalau tak back to isoelectric line, so it's not successful.
Reduced by 50% if not mistaken, doktor.
Yes, okay. So, dia kena ada reduction in the ST segment by 50% of the height lah. Kan? And also resolution of the symptoms. Tak semestinya chest pain, but restoration of the hemodynamic status. Kalau sebelum ni dia ada macam heart block ke apa kan. Lepas tu dah heart block dia hilang. Right? So, it's all the indication lah of a successful lytic therapy. So, that one you have to know Ini semua macam tak penting sangat lah in ED level, ni medical level lah. Right. But you have to know kalau you bagi your lytic therapy, then you kena ada your anticoagulant. Kalau you tahu dose, lagi bagus lah, or the regime. Tapi you tahu nama is good enough lah. So, Fundaparinox ni nama glamour dia Eristra lah. So, next slide. Okay, next slide. Ini semua tak ada apa lah. Okay. Next slide. Nabila kan?
Disposition.
Okay, so usually when you say management, dia kena sampai disposition lah, right? Okay, so the acute management, kena tahu, the acute management and then disposition and then baru the continuation of medication or treatment lah. Tu selalu ni susunan ni macam tu, right? Okay, so alright. Sepatutnya disposition dulu, baru dia continuation of you nak start bisoprolol, start ACE inhibitor ke kan. Sebab itu semua tak start dekat ED, itu semua start dekat ward kat atas.
Ni dalam ED setting, disposition dulu.
Yelah, habis takkan patient nak duduk kat ED selama-lamanya kan.
Betul.
So kita dah buat acute treatment, lepas tu kita masukkan dia ke CCU atau CRW, then dia continuation of medication or treatment dekat atas, right?
Okay.
Okay, alright. I think any questions so far? Are you guys okay? Dekat 2 jam dah ni.
Okay, doktor.
Okay tak? Ni senyap ni semuanya okay ke tak ni? Wujud lagi ke tak?
Okey, doktor.
Okay, doktor.
Okay, doktor.
So I think for this link tu boleh stop recording dulu. So nanti nak apa? Rest sekejap, 5 minutes break.